And now I would like to introduce our last speaker, Dr. Roberto Vasquez, Pediatric Oncologist, Division of Hematology and Oncology at Hospital Nacional de Niños Benjamin Bloom at San Salvador. So welcome, Dr. Vasquez.
Good morning. So this is an historical photo when we start the program in 1994 with the outreach program at the beginning. And during all this time, we have been being supported by people like Scott Howard, that is part of Resonance, like here. And we start to do a program in a only tertiary center for pediatrics in El Salvador, which is Hospital Bloom. And after 5 years of start everything, we report in Lancet, my boss in that time, that the outcome was increased in a very important way. So we passed to have data that the survival was less than 5% to 50%. That was very important at that moment. This is demographics. In El Salvador, our population is changing, and now the rate of natality has decreased a lot in the last 3 or 4 years. And now we are facing another group of patients that we have to take care of. And this is very important. That's why it's very important to follow things like demographics, like our national register that we have now, and our hospital register, because we have to follow these patients and to know what is happening with them during all the time we follow them. And that can last 10 years or 15 years. And this is very important. This is a very known slide that every oncologist has followed, and that is the St. Jude outcomes in acute lymphoblastic leukemia, how they doing continued protocols, they have improved a lot, and having a question that they have respond during the period of time that the studies have developed, and they have give us all the knowledge to know how can we treat people, how can we treat patients. But in low-income countries, we have done some kind of homework with that. And you can see this is the surveillance of our cases in El Salvador. And the data comes from ROPESAL, which is the Pediatric Register for Cancer in El Salvador, that is part of the hospital, part of the Ministry of Health, part of the foundation. We have been working together on this group, and we have improved in some specific kind of cancer. We need to improve in another that there's not so good results and outcomes. If you can see the curves that are in the base of the slides in the Kaplan-Meier, you can see we have acute myeloid leukemia, and we have some brain tumors that are not enough satisfactory with the technology and with the drugs we have for them. And this is very important. What we know in El Salvador, we know that when we talk about the prioritized kind of cancer, we have achieved some kind of good outcomes. And for example, in acute lymphoblastic leukemia, we have achieved more or less 75% of survival. In lymphoma Hodgkin is a good, we have a good results. In low-grade gliomas, we have good results because we have a very good communication with neurosurgeons that are in this are fundamental. And in Wilms tumor, retinoblastoma, Burkitt lymphoma, we are doing our job, but the others, there are not so many changes to have improved. What have achieved in the last 5 years with help, industry help people from Serbia. For example, in Central America, and this is our data from Central America, you can see what happened when we add pedasparginates to our protocols. And we have a protocol with 3 base risk branch. And you can see how even with very early time of follow, because it has like 1 year, there are some data that seems that with pegasparginates, that was coming from the donation from Serbia, we had improved our different branch of risk. And this was very important because in our country, we have not, and in Central America, access to Pegas vaginosa. And this was like an initiative that started by Sepierre as a company. Now is access, which is implying more drugs for more illness, more cancer types. And we want to be part of this. And you can see, but this is important for oncologists, but there is another group behind us, like psycho-oncologists, like nurses that are they have very good opinion about what happened with beta partners. Even we had faced some toxicity related to the therapy. We have been improved in a little time, in very short period of time of outcomes, and this is very important for the future. This is just an example of what is happening in Central America. What we would like to do in the future, we would like to increase our survival, but we are not by sure that this is not just a protocol problem. We have to solve all the problems around the patients to do more chemotherapy, to be more intensive. But for sure, we know that we can have access to drugs that can help us to that. And drugs that can help us to that are blinatumomab, but can reduce the intensity of the chemotherapy. When I was thinking about this meeting, I was thinking about what could be the advantage to have this drug in our countries for our patients. Well, we really know that the intensity of the chemotherapy is fundamental, but we need to improve very well our capacity of care of patients. Now we know that blinatumomab that can be an option in the future. We don't need to be so intensive with other drugs, and we can have good results. And even in the context of patients that could need a transplant, we don't have transplant available in most of the countries of Central America. Blinatumomab offer the chance to send a patient for an incredible effort out of our region to a transplant in the best conditions. That's why we have to think about it. So if we are part of this initiative, we know that we can be able to have access to these kinds of chemotherapy. And I was thinking, even in acute myeloid leukemia, now we know that, for example, venetoclax can be used in low-intensive regimens and incredibly increase the possibilities of the cure in that way. So it's another of the pathologies where we need to improve, and could be part of this opportunity to access. Transplant is still a very long distance from us. We have to do a lot of things. We have to work in other chances and in other areas, but it's part of the discussion, and we have to talk with the discussion with all the data. Well, we know that this could be available in the future, but not in the very short period of time. But Blina could be a real opportunity for our patients in the forthcoming years. And talking about CAR T cells is a possibility that is another chance, but is far away from our possibilities. So we are very happy to be part of the access and to talk about that. And every time we talk about cancer, about opportunities, we know that we have to continue to learn about cancer. Cancer is an incredible teacher. He makes us suffering a lot with our patients, but we learn every day, not only about the biological of the illness, we know about the reality of the human being around this big problem, and we have to be involved in that. When I was thinking about that, those are my thoughts to start the idea. I believe that El Salvador and Central America is doing a very good homework, preparing national registrations, preparing conditions to have an improving care for the patients. And we have some data that makes us feel comfortable to think about the future and to think about new drugs available for our patients that at the moment are not available because of the prices, because of the accessibility in the region. But we can go over that and find a way. Pegasparaginase is a good example. This is a drug that is not had no registration, commercial registration, but had been accepted by our national drugs regulatory entities because it's part of the protocol that is for care of patient free of shares, and that is very important because show us that there is a way always to get new opportunities in access for our patients. This is all I have to share with you, and if you have any questions, let me know.
Thank you so much, Dr. Vasquez. Regardless of technical issues, thank you for sharing the experience and your view.